This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Child's Nervous System, published in 2026. The title is Spring-Assisted Cranioplasty for Sagittal Synostosis, Long-Term Clinical and Patient-Reported Outcomes. 10-year outcomes of spring-assisted cranioplasty for isolated sagittal synostosis, a single-institution cohort study.
This is a significant piece of literature, Ilara. We've seen plenty of short-term and mid-term data on springs since they really gained traction. But a 10-year follow-up is exactly what the field needs to validate spring-assisted cranioplasty, or SAC, as a durable alternative to total vault remodeling.
Exactly. For our residents listening, sagittal synostosis is of course the most common form of craniosynostosis, leading to that classic scaphocephalic head shape. Historically, the debate has been between big open surgery, total vault remodeling, and more minimally invasive techniques. This study specifically looks at SAC, where we perform a sagittal craniectomy and place expandable springs to gradually widen the vault.
And the big question has always been, does that correction hold up as the child grows into their teenage years? Or are we just delaying a more definitive reconstruction? What was the cohort size for this study?
The study followed a single-institution cohort of patients who underwent SAC for isolated sagittal synostosis. What makes this study stand out is the 10-year outcomes mark. They didn't just look at the cephalic index, or CI, at the 1-year mark. They followed these kids until they were a decade out from their primary surgery.
Let's dive into those clinical outcomes first. The cephalic index is our primary metric for scaphalocephaly. For the students out there, that's the ratio of the maximum width of the skull to its maximum length. A low CI means a long, narrow head. What did the 10-year data show?
The results were quite stable. The paper reports a significant initial increase in the cephalic index immediately following spring expansion and the subsequent spring removal, which usually happens around 3 to 4 months post-op. But the key takeaway from the 10-year data is that this correction was maintained. There was no significant relapse into scaphocephaly. The CI stayed within an acceptable aesthetic range throughout the first decade of life.
That's a crucial point. One of the criticisms of less invasive techniques is the fear that the biological memory of the skull, or the restricted growth at the other sutures, might pull the head back into a narrow shape. This study suggests that the dynamic expansion provided by the springs creates a lasting morphological change. Did they mention head circumference?
Yes, the occipitofrontal circumference, or OFC. The study noted that head growth followed the normal centiles for the majority of patients. This indicates that SAC doesn't just fix the shape at one point in time. It allows for continued normalized calvarial growth as the brain expands.
Now, let's talk about the surgical burden. One of the costs of springs is that they require 2 surgeries, one to put them in and one to take them out. Did the study address complications or the need for secondary redo operations over that 10-year span?
It did. The reoperation rate for shape-related reasons, meaning patients who were unhappy with the aesthetic result later in childhood, was remarkably low. Most of the surgical interventions were limited to the planned spring removal. They noted a few minor complications, like localized skin infections or early spring dislodgement, but nothing that significantly altered the long-term trajectory for the patients.
That's a big win for SAC. If you can achieve a stable CI with lower blood loss and shorter hospital stays compared to a full vault remodeling, and that result holds for 10 years, the value proposition for the patient is very high. Speaking of the patient, this paper also emphasizes patient-reported outcomes. That's becoming a huge part of our practice.
It really is. It's one thing for us as surgeons to look at a CT scan and say, the CI is 76, this is a success. It's another thing to ask a 10-year-old and their parents how they feel about their appearance and their quality of life.
What did the PROMs, the patient-reported outcome measures, show?
The authors used standardized health-related quality of life assessments and specific aesthetic satisfaction scales. At the 10-year mark, both parents and the patients themselves reported high levels of satisfaction with the head shape. Interestingly, the study highlighted that the psychological impact of the scar was a factor. Because SAC uses much smaller incisions than the traditional ear-to-ear coronal incision used in open remodeling, the aesthetic satisfaction wasn't just about the shape of the skull, but the lack of visible surgical stigmata.
That scar burden is often overlooked in early infancy but becomes very important as children reach school age and adolescence. If we can provide a normalized head shape without a massive visible scar, we're doing a great service to their long-term psychosocial development. Did the paper touch on intracranial pressure?
Yes, though mostly in the context of long-term screening. None of the patients in this 10-year cohort required secondary decompression for delayed intracranial hypertension. The expansion achieved by the springs appeared sufficient to accommodate brain growth throughout the follow-up period.
So, if we're summarizing the key aspects for our residents, we have a 10-year longitudinal study showing that spring-assisted cranioplasty for sagittal synostosis provides a durable correction of the cephalic index, allows for normal head circumference growth, and results in high patient and parent satisfaction with minimal long-term morbidity.
Exactly. And to dive deeper into why this matters, the paper notes that the spring force is not just a passive spacer, it's a dynamic vector. By applying continuous lateral tension, the springs may actually influence the biology of the bone at the osteoctomy sites, which might be why the correction is so stable compared to a static fix.
It's that dynamic remodeling versus static reconstruction. In a total vault remodeling, we are essentially cutting and pasting bone into a new shape. With springs, we are guiding the body's own growth. The fact that the 2026 data shows this holds up at age 10 should give surgeons a lot of confidence in recommending this for infants diagnosed early, usually under 6 months of age, right?
Right. The study reiterated that the best results were seen in the younger infants, typically those operated on between 3 and 5 months of age, when the bone is most pliable and the brain growth is most rapid to help drive that expansion.
Any final thoughts from the paper's conclusion, Ilara?
The authors conclude that SAC should be considered a first-line treatment for isolated sagittal synostosis because of this balance between low surgical morbidity and high-quality long-term morphological and psychological outcomes. They really emphasize that the 10-year milestone is the new benchmark for evaluating any craniosynostosis intervention.
I couldn't agree more. If you're a resident preparing for boards or a case, remember, it's not just about the immediate post-op photo. It's about how that child looks and feels a decade later. This study gives us the evidence to say that for SAC, they look and feel quite good.
A great study to kick off the year.
Absolutely. Well, that's all the time we have for this episode. Thank you for joining us on the Neurosurgery Hub podcast.
We'll see you next time.